Wonderful. Hello, everyone. Thank you for coming to the EMS for Children Day webinar as part of the 50th anniversary of EMS Week this year. We're just thrilled to have people from all over the country come and all the great hellos in the chat. I'm Kathleen Adelgaze, and our webinar today is Pre-Hospital Pediatric Airway Management, and in honor of the theme of EMS Week, honoring our past and forging our future, we're going to cover this topic from the past, the current, present, and also share with you some exciting updates coming in the near future. So welcome. As I mentioned, I'm Kathleen Adelgaze. I am the Pre-Hospital Domain Co-Lead for the EMS for Children Innovation and Improvement Center. I also serve as the co-lead of the Pre-Hospital Pediatric Readiness Project. And in my own home state of Colorado, I am the project director for Colorado EMS for Children. So I've been involved in EMS for Children for about 2 decades now, and it's so near and dear to my heart, and just such an honor to be able to host this webinar for everyone today. Next slide. As a disclaimer, the EMS for Children Innovation and Improvement Center is funded by the Health Resources and Services Administration. However, we want to make sure everyone's aware that the contents of this webinar do not represent any official views of HRSA, HHS, or the U.S. government. And if you have any other questions or additional information, please visit hrsa.gov. And before we get into the heart of our webinar, we did want to share a video with everyone that was developed by Red Flash to support HRSA and EMS for Children, and also highlight Iowa EMS for Children. And I think that this webinar or this video will show how critically important this topic that we're talking about today is.
I put her to bed at around 8 o'clock, which is very normal for her. I went up to check on her about an hour later, and she was staring off into space. She was very hot. Her heart was racing very, very fast, and immediately I picked her up, and I knew that there was something wrong. I carried her downstairs, and I immediately called 911.
Mom was standing in the doorway and had Arlette just limp in her arms, very panicked. And I went in and I got Mom to lay Arlette down on the couch. When I assessed Arlette, I kind of went through the ABCs, airway, breathing, circulation. At that time, I knew that I was going to need more assistance, so I told Cedar County to page Lisbon Mount Vernon for a paramedic.
En route, we got the update that Arlette was unconscious. That prompted us to request helicopter assistance. However, they denied the flight request due to weather. And when we arrived on scene, did a quick pulse oximeter check and found her initial pulse oximeter to be 57%. With a good pleth wave, so it was believable. We administered high flow oxygen to her, which brought her oxygen levels up. However, she was still not breathing adequately on her own. Her CO2 levels were very high, which prompted us to switch to start ventilating Arlette with a bag valve mask. We decided to transport her to Iowa City, which was a little over 45-minute transport time. On the way, we decided to intubate Arlette. When we got to the University of Iowa and were directed to their pediatric trauma room, they gave us a lot of praise, pats on the back, and said we did a good job.
Having a team like the Mechanicsville ambulance and fire was amazing. I put my daughter's life into their hands, and they did everything that they could to ensure that she was okay. And I know that they saved my daughter's life.
Iowa has patches of very rural or remote areas, and our transport times for EMS can be really long. So it's even more important that our agencies are prepared. And these agencies prove that you can be ready, that you can train, that you can work together. And if they can do it, everyone can do it.
I have had the opportunity to help develop a national assessment so that we can know if each and every EMS agency in the country is ready to take care of children. It allows EMS agencies to be able to assess themselves to know where are the gaps where they could improve and what are they already doing well to take care of children.
Thank you. It's always just so impressive to see that. I've been able to watch that video a couple times, and it kind of overwhelms me each time. A little bit of housekeeping for today's webinar. There is CAPCE credit offered for those of us here today attending live, offered by Prodigy EMS. We've been so grateful to them for providing us with the CE credit. They've done this for the last couple of years for our EMS for Children Day webinars. And we will have instructions at the end with a QR code for everyone attending individually to get CE credit. In addition, we will at the end of the session have a Q&A that we'll conduct live. Participants are muted, but we will read off questions and answers that you can submit to the Q&A box in the webinar. Next slide. So I'm just honored to be here today with these pioneers in pre-hospital emergency care for children and who are going to talk about this critically important topic. We will start off with Dr. Marianne Gausche-Hill. She is a professor in clinical emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA. She is also the interim CEO of the Lundquist Institute of Biomedical Innovations, at Harbor UCLA. And she's going to cover a lot of her early work on the where we are today in terms of pre-hospital airway management. She'll be followed by Dr. Joelle Donofrio and Lorin Browne. And Dr. Donofrio-Odmann is the Deputy Chief Medical Officer from the City of San Diego and serves as the Medical Director of the San Diego Fire Department Paramedic School. She is an EMS and Pediatric Emergency Medicine physician at Rady Children's Hospital and an Associate Professor of Clinical Pediatrics and Emergency Medicine at UCSD. Dr. Lorin Browne is a professor of pediatrics and emergency medicine at the Medical College of Wisconsin and the associate medical director of the Milwaukee County Office of Emergency Management and EMS. And they together will share some of the current work on developing an evidence-based guideline and a summation of the knowledge around pre-hospital pediatric airway management. And we'll be finishing with Dr. Henry Wang. He is a professor and vice chair for research in the Department of Emergency Medicine at Ohio State University. He's the deputy director of the OSU Center for Clinical and Translational Science, and he is the lead investigator of the Pediatric Pre-Hospital Airway Resuscitation Trial, also known as PEDI-PART, being conducted through the PCARN Research Network. And we're just so grateful to have these incredible minds here today. We'll start off, the objectives of today's presentation are the following. First, we're going to review the seminal and early research in pre-hospital pediatric airway management with Dr. Gausche-Hill. We'll then provide some updates on the current recommendations on best practices for pre-hospital pediatric airway management. And we'll hear about that from Dr. Donofrio-Odmann as well as Dr. Browne. And then finally, we'll hear from Dr. Wang on his work to conduct the first largest trial of pre-hospital pediatric airway management to be done in children. Next slide. So let's talk about the past, which isn't too far in the past. It very much is part of the present today. We'll hear from Dr. Marianne Gausche-Hill, and I'll note that this next section is a video that she was gracious enough to record. Dr. Gausche-Hill joins us on her vacation on the other side of the world in Scotland, but she's here today to answer any questions in the Q&A. We wanted to make sure her information could be adequately conveyed with no internet issues, and so therefore she was willing to record this for us. Thank you, Joanna. Take it away.
Good morning and happy EMS week as well as EMS Day. There's birthdays all around with the 50th anniversary of EMS week. and the 40th anniversary of emergency medical services for children. My name is Dr. Marianne Gausche-Hill. I'm professor of clinical emergency medicine and pediatrics at the David Geffen School of Medicine, based at Harbor UCLA Medical Center and the Department of Emergency Medicine and Pediatrics, and our interim CEO of the Lundquist Institute for Biomedical Innovation at Harbor UCLA Medical Center. Anyway, I'm going to get started today. This is a fun topic for me. It's pediatric airway management, the past. I'm just going to take you back to the 80s because I think it's important to understand this was the time that emergency medicine was just becoming the specialty. There was no pediatric emergency medicine at this point in terms of certification, no EMS for Children program in the early 80s, no pediatric advanced life support, no trauma centers, and no national pediatric training for EMS providers. And so this is really where it all began. As you know, emergency medical services for children was funded for the first time in 1984, and the first grants were announced in 1985. And this turns out to be very important for me because it set up an opportunity for me to be able to do a very large randomized trial of airway management in children. And part of that time, I think the funding would have been impossible. And so Dan Inouye, Patrick DeLeon were instrumental early on in the passage of the EMS for Children Act. The other thing that happened, which really was a tipping point for me, was the first targeted issues grants were awarded in 1991. And this turned out to be serendipity and important for me to be able to fund this project. What's funny about this is that the targeted issues grants were really not designed for research. And so instead of calling my project research, I had to call it a project. And you'll hear about that a little bit more in a second. All right, this was really some of the literature that was coming out. You know, it's so important. Airway management in children was considered extremely important. And really the biggest question by my colleague at this time, George Fulton and others, was, do we intubate or not intubate children? And there was some early data to suggest that it was important for paramedics to intubate a patient in the field because early support of oxygenation ventilation was critical. And I believe that is true. And I think what I learned with this is that with every intervention, there are risks and benefits, and there's also the unintended consequence. So the background really here was for critically ill or injured children. Adequate management of the airway was really a vital part of pre-hospital care, although there was no high-level evidence that it actually improved outcomes. Many pre-hospital providers felt that the only way to manage the pediatric airway was the placement of an endotracheal tube. And indeed, in many of the protocols, it was just intubate. There was no even discussion of doing bag mask ventilation, although bag mask ventilation was really one of the, core interventions that pre-hospital providers learned, although I felt pretty strongly that their training in this relative to care of children was wanting, and that's something that we needed to address early on. So what was happening at this time was that pediatric intubation was becoming the standard of care throughout the United States, really without conclusive evidence, meaning that high-level evidence that I just mentioned, that intubation was successful. We knew that the success rates were extremely variable, although generally it was above 80% in terms of success for adults, maybe even as high as 95%, depending on what type of patient was being intubated, such as in cardiac arrest. But in children, it was quite variable and often around 50%. The other issue was that complications are high, and those were vomiting And in children, wrong size of equipment also played a big role, as well as aspiration. So this is the backdrop that led to a project that I started a number of years ago, the Pediatric Airway Management Project. And this was an amazing journey for me as an early researcher, and also created an important not only infrastructure, but a paradigm shift ultimately for the evaluation of pre-hospital interventions. We were funded initially by EMS for Children program through a HRSA, or Health Resources Services Administration Targeted Issues grant. And remember, we couldn't use the word research. We had to say it was a project. Also, we were able to get State of California EMS Authority funds through a federal block grant, and then ultimately to complete the project through AHRQ, Agency for Healthcare Research and Quality. So that was very helpful for us. And we also got funded by the American College of Emergency Physicians section grant to produce our training video to teach paramedics how to do pediatric endotracheal intubation. And then on the right, I reached out to really everybody to help support this project, because there really wasn't a great support overall for this type of research. And so I reached out to a number of corporations to supply some of these items for free with us for the trial. And then huge thank you to LA County EMS Agency, as well as Orange County EMS Agency at the time. And of course, the paramedics and the fire chiefs willing to do this project. So we wanted to compare the survival and neurologic outcomes of PEDS patients treated with bag mask ventilation, or those with bag mask followed by endotracheal intubation. Here's our original cover for the grant, the HRSA grant, and also the cover, or the notification of federal block grant funds at that time to help support EMS in general. And we were able to leverage that for support for this trial. On the right is my notice about the section grant for the video, and also NAILCOR. We were the first to really test the PDCAP, which is on the right, and they supplied all of the colorimetric CO2 detectors for us. We were trying to ensure safety. We trained over 3,000 paramedics in a 6-hour PEDS airway. We actually divided it into 3 hours, and they could be no sooner than 1 month apart in order to reinforce educational principles. And we did 614 courses over 2 years. We developed all kinds of educational materials, include an instructor manual. We produced videos on it, as well as you can see on the left, that's the student packet and study information kit, and then a series of objectives. And we had multiple layers of infrastructure, including a steering committee and an education committee as an example. The other thing that was critical is communication. We created newsletters, and you can see the first newsletter in 1994, and then the last newsletter in late 1997 when the trial was ended. As you know, it's a controlled trial, and we were obviously IRB approved by waiver of consent, and we did EFIC. This was before there were rules on EFIC, but we did have a data safety monitoring committee. And again, there was 830 patients that we did when we did our sample size calculation. We needed 800 patients, and we had 830. And only 10 were lost to follow-up. These are the various skills we did. We had to include McGill forceps and laryngoscopes. We felt it was not ethical to randomize, as an example, foreign body removal, so we included that. And we were one of the first trials who included systematically CO2 detection for care of children. Anyway, you can see here's our indications for airway management, basically cardiopulmonary arrest, respiratory failure. We defined that airway obstruction, trauma, and that head trauma, because at that time we felt it may be important, especially if the GCS was less than 9, to consider this. Here's our results. You can see the randomization process worked very, very well. We had, as I said, only 10 lost to follow-up, and we had very few protocol violations. And this is because we did a significant amount of work in explaining the why and what clinical equipoise meant to medics. Here's our outcomes. You can see there was no difference in survival there. Neurologic outcome, there was also no difference. And this is by intention to treat. And this is really important because there are factors that predict a successful completion of endotracheal intubation versus BVM. As an example, those who are most likely to survive, it may be difficult for the medic to intubate, meaning those that are easy to intubate are in cardiac arrest who have worse survival. So we were asked to analyze it 3 different ways. Obviously, the main result is intention to treat because that's the most. Paramedic intent was very little difference from our main outcomes, and that's because we had very few protocol violations. And then finally, treatment received, it looks like endotracheal intubation has worse outcomes. And this is because of the reason I said is that there's significant bias, and that's by intention to treat is really the way to report it. This would lead to you thinking that intubation hurts patients, and that's only because, again, the link to survival. So ultimately, patient survival and neurologic outcome were not affected by intended airway management. For endotracheal intubation, we showed prolonged scene times and that there were significant mortal complications such as esophageal intubation. Although it was low, it was important to understand that that could lead to a poor outcome. And we felt that EMS systems should really question the use of endotracheal intubation. And this was, as we published, these were probably the 3 main papers, the design of the trial, how long that the skills were maintained, and we demonstrated, although self-efficacy is high, the skills drop off pretty significantly, and why probably mandated training, if you're going to do this, is important, and most systems don't do it. And then JAMA in 2000 was when we published the main trial. This ended up being practice changing, and it's important to understand that doing these types of trials are critical for ensuring the right answer to the right question. And I'm going to go ahead and stop here, and I look forward to hearing everybody else's talks. And I just want to say thanks so much.
Thank you so much, Dr. Gausche-Hill, for that information. And there is a question in the chat about, or in the Q&A about King Airway, and we'll get an answer in there for the rest of the participants. With that, we will pivot to a hearing about the current information we have. Obviously, the critical research that Dr. Gausche-Hill conducted was really paramount for being able to develop evidence around airway management. And Dr. Joelle Donofrio-Odmann and Dr. Lorin Browne will review the current publications that are available and will be sent out in a follow-up set of resources after this webinar tomorrow for giving guidance on what EMS agencies should be doing around pediatric pre-hospital airway management. I did want to also let everyone know, given it is EMSC Day and there's a lot of activities going on around the country, Dr. Donofrio-Odmann, who is in the West Coast time zone, will be having to depart exactly at the hour so that she can conduct her own airway skills training there. So if you have questions for her, please put them into the Q&A earlier rather than later, and or we'll make sure that she is able to reach out by email for any other questions that pop up. And Dr. Donofrio-Odmann, go ahead and take it away.
Wonderful. Thank you so much. And it's great to be here. Happy EMSC Day. So if you'll notice, my talk has a lot of QR codes because what I'm going to talk about is some really pivotal papers and things that you should have in your back pocket. And instead of you looking at a picture, I actually want you to pull out your phone and scan the QR code and download it and save it and share it with your QA department and have it to talk about both for adult and pediatric airway management. So I'm going to cover the airway compendiums. So the National Association of EMS Physicians, the NAMSP, decided to champion airway management. The fabulous Dr. Henry Wang led a dedicated group of editors, each with breakout groups, to discuss in-depth pre-hospital airway assessment and management. We had literature review, like literally looking at everything, followed by expert consensus. And each section, so if you scan this, it's adult and kids, has your position statements with the supported evidence behind them. This compendium covers your education, training, quality improvement, ventilation, supraglottic airways, drug-assisted airway management, cardiac arrest, trauma, optimization of physiology, non-invasive ventilation, surgical airways, of course, pediatrics, and novel technologies and techniques. You need to save this and bookmark this and go back and resource this because this, published in 2022, is really where all the knowledge for pediatric and adult airway is for pre-hospital medicine right now. Next slide. But we're talking about kids today. So the pediatrics group, which had Drs. John Ling, Maria Nant, Matt Harris, Dr. Gausche-Hill, Dr. Tony Gross, Dr. Brian Moore, and myself, we created 3 different pediatric position papers with supporting resource documents, focusing on education, quality management, and interventions. Next. We started with education because you need to have solid assessment skills on the front end to get you earlier recognition of respiratory distress and failure. Airway management is not a single moment in time. It's a continuous process throughout the entire patient care. You need to have early education to establish competency and mastery, and longitudinal education to maintain your skills. From recognition of, is it upper versus lower respiratory distress, to apnea, and selection of the correct intervention for appropriate oxygenation and ventilation of your patient. Next. So Dr. Ling actually created this, this figure, which I think is really illustrative. As you can see, as the invasiveness of your intervention increases from supplemental oxygen all the way up to surgical airways, your frequency decreases. Your difficulty level increases. And importantly, the effort needed to maintain your competency increases. And this is important to think about for your individual provider, as well as your agency as a whole in your training. Next. This quality management position paper focuses on how do we move the mark forward for pediatric respiratory distress and airway management? How can we collaborate with professionals who have expertise to set benchmarks for performance for local, regional, and national standards? This includes your pediatric patients in respiratory distress from bronchiolitis, croup, asthma, all the way through your patients with respiratory failure requiring invasive airway management. Quality management should look at quantitative success and qualitative performance. It's not just how many times did you get something, but why did you do it? How did you get there? Was it an appropriate intervention based on the level of distress? Do you have benchmarks and standards? I'm going to pause here because if you're watching this, I actually want you to think about your own system. Do you have benchmarks and standards currently? Next. And lastly, we hit the actual interventions used for pediatric airway management. all the way from the use of pulse oximetry and end-tidal capnography, which is far more interesting than you would think, especially with the neonates, all the way through the actual interventions. This paper covers all the way from supplemental oxygen, non-invasive ventilations of heated high flow nasal cannulas, CPAP, BVM, through invasive airways to supraglottic airways, endotracheal intubation, apneic oxygenation, DL versus EL, drug-assisted management. We hit all those topics in this paper. But there's two position paper statements that come out of this that you should be aware of. Next. When we did the lit review, while the pre-hospital literature was lacking, really because the retrospective studies have had supraglottics really be a rescue device after failed intubations, there's a lot of supportive evidence in the hospital. And so we actually came together to support supraglottic airways as being a primary or secondary airway for pediatric respiratory distress or pediatric respiratory failure in cardiac arrest in the EMS setting. Next. However, the literature showed that pediatric intubation is actually incredibly low frequency. It would take 8.8 years to get every medic in the county of Los Angeles one pediatric airway. There is no definition of competency in pediatric intubation pre-hospital. Your odds of a successful intubation in a child under 2 is about 50%. And the indications for intubation aren't clearly established. For example, about 20% of patients in the pre-hospital literature for kids were for status epilepticus, which is more often about getting the seizure to stop with medications while controlling their oxygenation and ventilations, and often no intubations needed, and sometimes we can even get them home from the emergency department, which led to this position statement that pediatric endotracheal intubation has unclear benefits in the EMS settings. Advanced approaches to peds endotracheal intubation, including drug-assisted airway management, apneic oxygenation, and use of DL and VL require further research to more clearly define the risks and benefits prior to widespread implementation. Next. However, huge caveat, whether you are an agency who does not intubate, an agency who does intubate, or one who's considering changing your practice, don't forget, we use the DL and VL, if you have it, equipment for foreign body airway removal. These are life-saving. So remember to keep your pediatric equipment so you can go ahead and use your McGills and do foreign body removal. Next. So in summary, the compendium, have it, know it, keep it in your back pocket. There's a lot of stuff. For pediatrics, we specifically go into your education, your quality management, including quantitative and qualitative, and we go really in depth on pediatric interventions. Next. And up next is the fantastic Dr. Browne.
Thank you, Dr. Donofrio. So, and happy EMS week. Welcome to EMSC Day. Thank you for spending a little bit of time with us. We're really excited and passionate, as you can see, about this topic. Dr. Donofrio set the kind of the standard with where we are, with a very intense review of the literature. We're going to take it now just a little step further. We're going to talk about the National Association of State EMS Officials Pre-Hospital Airway Evidence-Based Guideline work. The work that we were involved in to develop this EBG was aimed to develop and update the Pre-Hospital Airway Management EBG. It was funded through efforts by the National Highway and Traffic Safety Administration through the Office of EMS. They leveraged a prior AHRQ systemic review we'll talk about shortly now. Next slide. The systemic review really aimed to identify and synthesize where we are with the available evidence in terms of airway management in the pre-hospital setting in both adult and pediatric patients. It was designed in advance to support the development of an airway EBG. The systematic review focused on really all the ways in which we can manage airways in a pre-hospital setting: bag valve mask ventilation, supraglottic airway device placement, and endotracheal intubation. In contrast to the compendium, which really looked at all available literature, the systematic review really focused on randomized controlled trials of airway management in a pre-hospital setting. Though they did include prospective and retrospective comparative observational studies and case control studies if the RCTs were insufficient to answer the question. Next slide. The outcomes the systemic review addressed included morbidity and mortality and hospital length of stay following their pre-hospital care, overall and first pass success and number of attempts for both supraglottic attempts and endotracheal intubations, the effectiveness of oxygenation and ventilation with each of the airway strategies, and then adverse events and harms that were observed in the literature. Next slide. So the NASEMSA was tasked and funded to take the AHRQ systematic review, which identified 22 population intervention comparison outcome questions, and then to assemble a technical expert panel to evaluate the literature that is available using a standardized methodology called GRADE. GRADE is a standardized way in which you can review the literature, you can ascribe the strength of the literature, and identify any biases in the literature to help identify and develop your EVG. The technical expert panel consisted of 19 individuals who were experts in adult and pediatric airway management, EMS physicians and medical directors, EMS clinicians, educators, and researchers, and a single evidence-based GRADE methodologist. This technical expert panel met over several months. They reviewed the evidence in the form of summary tables. They then reviewed these on their own time and participated in asynchronous online judging, where they assessed the value and the strength of the evidence. And then we had a number of video conference facilitated discussions that were quite in-depth and quite informative as we developed the evidence-based guidelines. Next slide. So this table shows the 22 questions that were identified. The key questions were bag valve mask versus supraglottic airway, bag valve mask versus endotracheal intubation, and supraglottic airway placement versus endotracheal intubation across several different populations. So we looked at both the adult and pediatric populations. And because not all patients are created equal, we did look at these airway management strategies individually in specific disease states. So out-of-hospital cardiac arrest, medical causes of respiratory failure, and traumatic causes of respiratory failure. Because this was the way the literature is structured and the way that we felt it was nuanced enough that we had to be absolutely certain which airway strategy was best or most favorable in these specific populations, we can't basically come out and say with our results that this one airway strategy is the penultimate airway strategy in all situations. It is nuanced enough that we need to look at it in this level, to this level of degree. We also attempted to answer some questions about the technique modifiers with endotracheal intubation. So we looked at no medication versus rapid sequence induction, sedation assisted versus RSI, no medication versus sedation without paralysis, and then the effect of direct versus video laryngoscopy. We did those across all populations, and these were agnostic to specific populations or specific medical condition. Next slide. So our outcomes, our high priority outcomes included survivability and good neurologic function. And our intermediate priority included first pass success for supraglottic airways and endotracheal tube placement, overall success for those modalities, and then return of spontaneous circulation in the field for those in cardiac arrest. Next slide. So here is the big reveal of what the evidence-based guideline found. So all of the recommendations provided by the evidence-based guideline are conditional. This means that there is not strong enough evidence to support one practice in every situation. And the consideration to your resources situation, the resources available in your agency, need to be considered as you choose which airway maneuver is best. Also, the strength of evidence was not very high in the existing literature. So you'll see on this slide that those findings that are highlighted in orange are the ones that have very low certainty of evidence, while the ones in blue have low certainty of evidence. So looking at our bag valve mask versus supraglottic placement, that's our first column. The panel found, the EVG panel found that for out-of-hospital cardiac arrest and trauma in adults, that either BVM or SGA were favorable. The literature was not conclusive on one winning over the other. For medical arrests in adults, there was not insufficient literature to provide a recommendation. The findings were similar in children for bag valve mask versus supraglottic airway. That's the bottom left-hand corner of the table. For out-of-hospital cardiac arrest in pediatrics, either bag valve mask or supraglottic airway are favorable. And for trauma and medical causes of respiratory failure, there was no recommendation that could be provided because the evidence was lacking. In bag valve mask versus endotracheal intubation, again, now we're on the middle column. In the adults, out of hospital cardiac arrest and trauma, again, either bag valve ask or endotracheal to intubation are favorable. We could not recommend one over the other. And the medical causes of respiratory failure, no recommendation was possible. But in the pediatric side, and since it's EMSC Day, we'll focus on this. We did find that the literature favored bag valve mask over endotracheal intubation for out-of-hospital cardiac arrest in pediatrics. For traumatic causes of respiratory failure, we did find that the evidence was favorable for either bag valve mask or endotracheal intubation and did not favor one over the other. And again, in the medical causes of respiratory failure, we were unable to provide a recommendation secondary to low, insufficient evidence. Now, finally, on that last column on your right, supraglottic airway versus endotracheal tube intubation. This is the one where we find the clearest distinction in the literature. First, for out-of-hospital cardiac arrest, for agencies that have low proficiency in endotracheal intubation because the opportunities are not there, because they encounter so few opportunities to intubate, the literature does favor supraglottic airway over intubation. In all other agencies, including those that have high proficiency, which that means they have high resources dedicated to training, maintenance of competency, and QI efforts around their airway maneuvers, then either SGA or ETI was favorable. In adults, again, SGA versus ETI for medical or trauma, the literature would indicate that neither one is favorable to, or they are both favorable, neither one is favorable to the other. And finally, in pediatrics, in the SGA versus endotracheal intubation, it was the literature does favor SGA for out-of-hospital cardiac arrest and trauma, and then favors either SGA or ETI in pediatric respiratory arrest for medical causes. Next slide. And then finally, in our technique modifiers, RSI is favored, again, in high-functioning systems over no medication. RSI is also favored over sedation assisted. We were unable to make recommendations based on the insufficiency of the literature when it came down to no medication versus sedation without paralysis in intubation attempts. And then either direct or video laryngoscopy were favorable. One was not favorable to the other in intubation attempts. Next slide. So finally, what we see when we reconcile the compendium and the NSEMSO EBGs, because their findings are slightly different. They did employ different methodologies, most notably the compendium considered a wider variety and wider array of literature than the NSEMSO EBG did. That led to slightly different recommendations. However, there is a consensus that overall, airway interventions are infrequent, they are difficult, they're costly to train and to maintain competency, and they are associated with increased complications. So now we will conclude this talk by hearing from the wonderful Dr. Wang and where we're going with this work in the future.
Thank you so much, Dr. Browne. And so as Dr. Browne alluded to, we're now at the point to talk about where are we going? Given the information that's available in the literature today, that we got a beautiful review on, and recommendations for what EMS agencies need to do, who are putting into policy practices for airway management, we want to enhance that knowledge and that evidence for next steps. And that really brings us to the future and Dr. Wang's presentation on the pediatric prehospital airway resuscitation trial. Dr. Wang?
Good afternoon and happy EMS Day to everyone. I'd like to talk about the Pediatric Prehospital Airway Resuscitation Trial. We are so excited about this brand new research study that's taking place in 10 communities across the United States, and in fact began enrollment this week. Go on to the next slide. Okay, my colleagues have highlighted the important role of airway management in the history of EMS, the challenges of successfully implementing advanced airway management practices in the field, and the important unanswered questions about the science of airway management, particularly in children. Go to the next slide. The existing data scream out the need for a new clinical research trial to inform pediatric prehospital airway practices. To get to a new trial, we need to recognize the challenges and important considerations for such a project. So unlike in adults, where most airway cases are in cardiac arrest, in children, we think that they are divided equally between cardiac arrest, trauma, and respiratory failure. There are 3 families of airway management devices: bag valve mask, intubation, and a newer supraglottic airways. Okay. And pediatric encounters are high stakes, but they actually happen more rarely than in adults. So to get to adequate numbers of subjects, you'll need a very large research network with a very high pediatric acuity. If you were to set up separate research studies to answer all potential questions about pediatric airway management, you would probably need a sequence of projects involving 15,000 total patients, a number that's simply not feasible. Go on to the next slide. These considerations set the stage for our new PD parts trial. The objective of our trial is to determine the best paramedic strategies for managing the airway in critically ill or injured children. This is a project that's supported by $14 million in funding from the National Institutes of Health. Go on to the next slide. The trial will include children 1 day old up to 18 years old, actually under 18 years old. It will include children requiring active airway management for cardiac arrest, major trauma, or respiratory failure, and will involve cases cared for by EMS agencies affiliated with the research trial. Next slide. Then the trial interventions will include bag valve mask, supraglottic airways, as well as endotracheal intubation. The participating EMS agencies will use their standard equipment as well as their standard techniques, and will adhere to training practices that currently exist for their agencies. Go on to the next slide. Now, in a traditional randomized trial, you set and forget the target number of subjects for the study. Once the trial starts, you do not take a look at the results until you've reached the target enrollment. The basketball game lasts exactly 40 minutes, and you do not look at the score or declare a winner until you finish the game. PD part will use a funkier adaptive research design. And while it has this long name, we affectionately call this March Madness. The trial will be conducted in 2 stages. In the first game, bag valve mask will compete against supraglottic airways. And the winner of stage 1, the winner of the first game, will go on to compete against intubation in the second game. Go on to the next slide. Furthermore, the length of each we can study over this limited time period. The initial plan is to enroll about 1,500 patients in each stage or each game. However, the statisticians will be taking sneak peeks every 300 patients to determine if there is an early winner or if there is a clear tie. If game 1 ends early, then we start game 2 early, reallocating the available patients to the second game. If game 1 doesn't show a clear winner and we need to go into overtime, then we keep enrolling subjects until we see a definitive answer, even if we have to cancel the second game. We think it's going to take about 4.5 years to get through the bracket. Next slide. So why this funky design? All studies have limited resources. This approach lets us answer all of the important questions with the resources available. We accept the possibility that we may never get to the second game, but that's okay because we will have a definitive, clear answer to the first question rather than risking having 2 indeterminate answers. Next slide. In a randomized trial, you're always concerned about randomly flipping the coin and assigning patients equally to both interventions. In PD part, we'll be using an odd even day assignment. So for example, in stage 1, on odd days, paramedics will perform supraglottic airway insertion, and on even days, they will perform bag valve mask ventilation. This is the same strategy used in Dr. Gausche-Hill's study 25 years ago in Los Angeles. Go to the next slide. Now, we know that remembering odd even day assignment is really tough, especially when you're in the middle of a very busy 24-hour shift. And so we created technologies to make this process easier. Here's QBERT. This is our QR code-based emergency research reminder technology. That QR code, in fact, is live and will tell you the assignment for Columbus Division of Fire in Columbus, Ohio. And you can see that that QR code will show you what intervention a medic unit is supposed to perform for any given date and time. Go to the next slide. And because mobile signals are often not available, we also created Ralph, which is a portable beeper-like device, again, providing reminders of the odd even day assignment. Next slide. The primary outcome of the study is very important in a research trial. Are you trying to show survival? Or are you trying to show good neurologic function? In PD part, we are using ICU-free days. And this is a concept of how long you are spending in the intensive care unit as a patient. If you spend fewer days in the intensive care unit, we assume that you are better. And if you spend a long time, we assume that you are sicker. The ICU-free days gives us the flexibility to study this topic, but use the very sophisticated study design. Go on to the next slide. So what about ventilation? Isn't the point of airway management to manage the delivery of oxygen to the lungs? An important feature of PD part is that the paramedics' cardiac monitor files record all of the care delivered to patients enrolled in the trial. And this includes the chest compressions and the ventilations detected by exhaled carbon dioxide. Our study will collect all of these data files from the Stryker and Zoll cardiac monitors to give us real-time perspectives of airway management delivered to each patient. Next slide. One limitation of measuring ventilations by end-tidal capnography is that it only measures ventilations when you attach it to an endotracheal tube or supraglottic airway. It misses the ventilations delivered during bag valve mask ventilation. Thanks to research that our group has been doing over the last 10 years, we have now developed a way to see the ventilations from the ECG thoracic impedance signal. And this way we can see the ventilations delivered even if the capnography device is not attached. Go on to the next slide. So how do you obtain informed consent for participation in a research trial when the patient is unconscious? PD part will be run under Food and Drug Administration rules for exception from informed consent. And these are regulations that were developed 20 years ago, recognizing that many of the world's most important burning scientific questions involve unconscious people in emergency conditions. There is simply no way to get permission from a patient or family members. The EFIC rules have been used in a range of emergency care research in the past. Community engagement, termed community consultation and public disclosure, is a very important part of EFIC. This is the requirement that we go out into the community, spread the word about the trial, and get feedback back about the trial. Go on to the next slide. An important feature of PD part is that we use social media as part of the community consultation process. Social media is the way we communicate and share information in 2024. It's a very current method of communication. We place Facebook and Instagram ads in all of the study communities. These ads would take readers to the study website where they can get more information about the trial and answer a survey with questions about community opinions about the trial. Go on to the next slide. PD part is going to be a monumental effort. Here are the 10 cities participating in the PD part trial. Approximately 1,000 children each year requiring active airway management. Next slide. And lastly, this is the all-star team that's very faithfully supported me during the development of the PD part trial. We began brainstorming PD part in 2018, meeting weekly for almost 3 years straight, if not longer. And this trial would not be possible without the incredible input of all these incredibly bright and talented individuals. And I think you will recognize that these are some of the most important names, not just in EMS, but pediatric emergency medicine. These are the superstars that made this study possible. Go ahead to the next slide. PD part started enrollment late last week, and we enrolled our first subject this week in Columbus, Ohio. We hope that this example set by PDPAR will inspire all of you everywhere in EMS to deliver the best possible care for our youngest patients. Thank you very much.
Congratulations, Dr. Wang, on getting your first patient enrolled. That is really incredible. And thank you all for presenting. And we have a few open questions in the chat that we'll get to. In follow-up to some of the questions that people did have about being able to do your CE, here is the link here, the QR code. Again, we will send out a letter, email tomorrow to all of you who have registered with this link directly on it. And if you're having any difficulty getting your CE credit, please reach out to the Prodigy EMS.com. We do have a poll for an evaluation of this webinar that's going to be shared now. So we know that it's a little later in the day for some of you, but hope that you can stay on for the next half an hour of time if you have it till we get through everyone's questions. The Q&A has been raging, and there's a lot of really valuable questions that people are asking about there. Please also, again, do the EMSC Day poll that is up for you and will stay up for a period of time to capture so many of our amazing attendees today. As an update, we wanted to, again, plug the Pre-Hospital Pediatric Readiness Project assessment. We heard in the video at the very beginning from Dr. Manish Shah, who has been involved not only in the PDPART trials you just saw in one of the last slides, but also in helping develop this assessment. There are over 2,500 EMS agencies who have completed the assessment so far since its release in May, and you can go to this link. This is to be done at the EMS agency level. So if you don't feel like you're the right person to do it, please share this information with somebody in your EMSC leadership to get them to complete the assessment. You can go to the EMS Peds Ready website and download a paper assessment and use that to bring this information, get some information on how to answer that. Next slide. I also did want to let everybody here know about the Pediatric EMS podcast hosted by Dr. Donofrio-Odmann and Dr. Joseph Finney. Stay up to date on pediatric EMS, all things pediatric. It's available where you download your podcasts. It can also be found on the National Association of EMS Physicians, or NEMSP website. And they have had quite a few important educational things and updates that they talk through on that podcast. Next slide. And so with that, we do have a few open questions in the chat that I was going to ask some of our panelists to help answer. And so one of the first questions that is out there is, and I think this might be for Lorin, why was ROSC considered an intermediate over high priority in the evidence review?
Excellent question. Obviously, from a clinical standpoint, ROSC is what we're trying to achieve. From a boiling it down to what is important from an airway standpoint, there are so many variables that go into whether or not you achieve ROSC, that it is not just tied to how quickly and how effectively you can manage an airway. It is important that it's not the only thing. And so to avoid confounding the situation, we really focused on those airway or those primary objectives that we thought more tied to airway management. But very good question. And I hope that answers sufficient.
Awesome. There was somebody that mentioned in the Q&A, as somebody who's moved from intubating in a big city to smaller communities, and how there's been real significant fluctuation on this nationally. And again, as you know, we've heard from Marianne, Dr. Gausche-Hill, and as well as Dr. Wang, the real critical need to kind of get some good data on next steps in this area. Tom McKay asks, is impedance reading influenced by AP versus apex-based pad placement? And that might be for you, Henry.
It's a very advanced question. Let me put it this way.
Tom, you are advanced.
Our understanding of ventilation, believe it or not, is very much at the beginning stages. And part of the tough part is simply measuring the ventilations delivered to patients. So expect better answers to the ventilation question as the trial evolves, as our technology evolves, as we develop better computing techniques to do these analyses. You bet there's a lot of machine learning and AI in our future for this particular topic.
Thank you. Ann Edwards asks, is each participating agency sharing social media or being tagged with information about the study?
Social media campaigns were performed in the earlier part of this year in the metropolitan service areas of all of the cities participating in the trial. And look online for additional information that will be shared as the trial progresses.
Thank you. Some people have asked about whether this will be available on and we will have this recording actually on the EIC website under our EMSC Day, so that we can get make sure other people who couldn't attend live or got interrupted in their ability to participate. So Tom, I just want to get back to you, make sure your question was answered effectively by Dr. Wang. He was referring to if the impedance reading was affected being able to see ventilations. Dr. Wang.
Yes, so the impedance readings can be affected by, for example, the size of the chest. Children tend to be a little bit smaller than adults. And so we're actually confident that we have an easier time seeing the ventilations with that technique.
Wonderful.
We have a question from Dr. Antevi in the chat. Peter asks, curious on thoughts of delayed sequence intubation versus rapid sequence intubation when evaluating intubation arm in non-arrest patients. The use of drugs for intubation, of course, is a necessary part of our practice, and of course, it makes the science very complicated. We have not restricted the use of specific drug techniques in the trial. We expect that a randomization will sort them out in equal distributions between the different groups. Stay tuned for more detailed perspectives on that topic.
I don't know if Peter was referring to, as an example, in sepsis, the recommendation is to fluid resuscitate prior to doing airway management to try to fill the tank and be ready to use a pressor if RSI is used. So I don't know if that's what you meant, Peter. I don't. Anyway, if you want to put in the chat.
While we're waiting on that, there's a question in the Q&A. Any advice or considerations with intubations of a peds asthma exacerbation? Obviously, asthma is common, and needing to intubate is such a rare event.
Lorin and Marianne, I'll turn that one over to you.
One of the challenges is going to be doing it. Well, if you're talking about the pre-hospital setting in the airway trial, we didn't see any difference in the subgroup with bronchospasm with BVM versus ET. I will say that the challenge with doing ET in that setting without RSI is really great because they often have clenched teeth. So it really can be a challenge, but I think we found that in all subgroups, the paramedics were able to do BVM about 85, pretty much 85% of the time without troubleshooting.
Wow. There is another question about any advice for providers in the search and rescue setting and dealing with these types of pediatric emergencies. That's a tough thing.
Marianne, Lorin, do you have specific perspectives here?
I'm
Yeah,
gonna
maybe Lauren.
pop out on the answer just a little bit, because I do think that as pediatricians, sometimes we do our general providers a disservice by telling you that pediatrics are always different. They're not always different, right? 90% of the time, what you would do for an adult is applicable to the child. You just need to know the nuances. And so when you're managing the airway of a child, right, it is the mechanics are the same. The indications are largely the same. And so we need to do a better job of reinforcing the skills that you have, and making sure that you know that you are, in most cases, really competent to take care of the airway of a child. You just have to be a little more gentle. You have to bag a little with a little less volume, but it's always about making the chest wall rise. It's always about making sure that you've got good oxygenation and good ventilation. And so I don't have any good tricks or trades, but just don't doubt yourself quite so much, because I think we want you to sometimes we feel like we got to teach it to you all over again. And that's just not always the case.
Peter does get back to your question. And we use DSI, meaning we give ketamine, pause for 3 minutes, then give the paralytic. During the pause, we oxygenate and fluid resuscitate. The outcomes are better, including FPS without hypoxia and hypotension. And Marianne, I see that you're putting an answer into the chat.
I started to put an answer in. I was just going to say to Peter, that is the recommendation for sepsis as an example, in the in-hospital setting. In the out-of-hospital setting, I don't think there has been a recommendation besides oxygenation and fluid resuscitation. But with that said, if yours is in the pre-hospital setting, it'd be great to get that published.
There's a couple additional questions in the chat about the PD part trial. I thought that you could answer, Henry. How were the agencies chosen? And how can an agency be involved? Is it still open for agencies?
Unfortunately, we're not open for additional agencies at this time, but as the trial evolves, it's always possible we could expand. The agencies have been identified for this trial for several years now. It involved a combination of high volume, high acuity experience with research, experience with caring for critically ill children.
Thank you. Oliver Hamilton put into the chat, what is the preferred supraglottic airway device in the pre-hospital setting? His agency recently switched from King's to iGels.
I don't think there's clear consensus on the optimal supraglottic airway. As you've noted, there's a general trend towards using iGels. However, AirQs are becoming very popular. And don't dismiss the King LT. It has many appealing features, and it's been tried and true for many years now, especially in children.
Ruben Markowitz asks, I'm just concerned with the ethical nature of the odd SGA versus the even BVM days. Would it not cause providers to perhaps hesitate in what they believe to be the correct course of action? How would it relate to regional protocols as well?
So a very good question. In fact, brought up by paramedics in the study EMS agencies. The odd even assignment is the scientific assignment of the preferred strategy for that day. But as with all research studies, if a healthcare provider or paramedic feels that something needs to be done because of a clinical situation, they're allowed to change the intervention. And so, for example, if back valve mask is not working because of bleeding and vomiting, and they feel that intubation is necessary, that is very much permitted within the research study.
Thank you. Cloud asks, did you consider using a ventilation feedback device specifically designed to accurately monitor the tidal volumes delivered with each breath? Wouldn't that be more precise than the thoracic impedance curves that you plan to use? Got some high-tech questions in the
yes,
group today. Really impressive.
I appreciate Cloud's very astute question. And also remember that children are very different. So the monitoring technology that he's alluding to does not work on very small children. And so again, this is an evolving field. We have a perfect storm of opportunity where we have a clinical trial of airway management coupled with very early technology to help us better understand ventilation. And our ability to understand ventilation gets better with each year. So when we finish the trial 4 years from now, we will have perfected many of the techniques needed to thoroughly understand how the oxygen is going into the lungs.
Awesome. There are so many amazing questions here. I see that Dr. Gausche-Hill is answering Eric Bonilla's question. In regards to RSI, I've read and heard different arguments on succinylcholine versus rock. Love to hear your opinions on this. I'm not sure, Dr. Gausche-Hill, if you want to speak up about that.
Yeah, just briefly, I think that succinylcholine has been shown to have, more rapid intubation conditions than rock. However, rock, succinylcholine, if there are contraindications for it, if you double dose, it may cause bradycardia. So that's a concern with kids with muscular dystrophy or cerebral palsy as an example for release of potassium. So given that we have Shugomedics now, which is Bridion, which is a reversal agent for rock, I think most places are favoring rock. And I would use 1 milligram per kilo for rock. And then if indeed you have to rapidly reverse, I would use 16 milligrams per kilo of Shugomedics. Sorry, I started to type, but it took too long.
No worries. Alec Page asks a question for you, Dr. Wang. Their agency is about 15 minutes from Nationwide and was told to load and go, especially being so close to Nationwide Children's Hospital. What are your thoughts about staying on scene to run an RSI versus bag mask ventilation without an RSI or intubation?
Easy answer. We don't know the right answer.
Yeah.
Stay and play or scoop and run. And you've highlighted one of the big controversies in EMS. For years, we've been teaching scoop and run for almost all of our most critical emergencies, but now we're realizing deliver high quality seat chest compressions and ventilation. And so stay tuned. We actually don't have the right answer for that question yet. Sorry, I was probably cut out, but you can.
It was just a brief pause, but I think we got the gist of your answer. There was a question about from Lloyd. He didn't hear anything about newborns with out-of-hospital births in neonatal or NRP. That's a big focus on intubation. Will newborns be included in the study?
PD part specifically excludes newborns. That's why we have that very odd 24-hour-old minimum age. We want to exclude any births that might happen in birthing centers or at homes. Those are very different situations, and the airway management techniques and priorities are very different.
And then there was one more comment or a question from an anonymous attendee about a peds doc who attempted to intubate an infant with no medication support, and they attempted 7 times and then called anesthesia. Can you comment on this practice without medication or little sedation?
Well, I can't comment on that particular situation, but I would like everyone to reflect upon the bigger message that we're trying to send with this research study. When people hear about airway management research studies in the pre-hospital setting, they think it's about taking away interventions. It's not about taking away intubation or taking away supraglottics or other techniques. It's about helping us to understand the best strategies for optimally caring for the airway in this very crazy pre-hospital environment, which includes a lot of distractions, a lot of noise, a very sick patient, a very small patient, and all of the other things that we have to choreograph in the middle of the giving care for this patient. So we emphasize that these research studies are about strategies of care and how we can best efficiently manage the airway in the chaos of the pre-hospital environment.
I think these really tough questions. Taylor asks, as for ventilation in pediatrics, are all the departments utilizing a standard set of equipment, bag valve mask, ventilation inline pediatric end-tidal CO2, or are they using their own equipment? If they utilize their own equipment, is dead space and FiO2 being accounted for in ventilation and oxygenation?
Taylor, that's a very good question. All the agencies are using their own standard equipment. Yes, there are variations in the size and types of techniques that are being used. When you put together a large multi-center randomized trial, part of that rationale is that these differences will even out as you increase the sample size and increase the number of sites. And once again, this is why a national multi-center trial is such a very special opportunity to answer an important scientific question.
And James asks a question for all. Does anyone have any advice on securing pediatric, infant, and neonatal tracheal tubes in the pre-hospital setting? Do you use any particular device or method?
Marianne, Lorin?
Many tape in. There are endotracheal tube holders. I don't know if there's a pediatric version now on that, frankly. But if you tape it, I always say tape it like you mean it. You go from the maxilla around the tube to the other maxilla and make sure it's dry. That's what we recommend. And that's true for the supraglottic and the iGel devices as well.
Important pearl, supraglottic airways have to be secured or taped in place. I've seen that mistake made in the field. You see it put a king airway in, it seems like it's held in by the balloons, but it can be easily dislodged.
And I think if there are no other questions in the chat that I can see thus far, there is one question about pediatric volume. Rachel, can you read that question? I'm having a hard time finding it in the chat.
Yeah, it was a follow-up for what is defined as high volume for the study participants, total EMS contacts or pediatric contacts, or something else?
If you're talking about EMS agency volume, our highest enrolling sites, we expect to be caring for about 100 pediatric airways per year.
Awesome. Well, I think that the other questions we have addressed at this point, and we're almost at the full hour and 30. It has just been incredibly impressive. The scope of the questions, the interest from our attendees. This is our highest number ever of participants in an EMSC Day webinar, and I just can't thank you all enough for taking the time to be here after hours, across an ocean, and everywhere in between. So thank you to our panelists and thank you to all of the attendees today. So please go to the EMSC Day materials and resources. We have resources there for you for EMS Week as a whole, and then additional resources on the PPRP toolkit, which we did put in the chat, and then we'll follow up by email with additional resources presented in today's webinar. Really, thank you so much for being here today.
Hey, Kathleen.
Yeah.
I think one last in conclusion question. Somebody's asking, at this moment in time, should pre-hospital providers be more aggressive towards a quick SGA or towards ETI with patient contacts, with shorter patient contact and transport times?
Depends upon the situation. It depends upon the patient, the distance to the hospital, as well as your individual airway skills and your equipment. So I encourage everyone to work closely with your medical directors to come up with the best solution for your EMS agency.
Thank you.
Thank you all.
Good night from Scotland.
Thank you.
It's late here.
Thank you for joining.
Get some rest so you can go enjoy tomorrow.
Yeah, thanks. All right, guys. And bye.
Bye-bye. Crushed it.